This conference will now be recorded.
Good morning, everyone. Am I audible?
Yes, sir.
Okay, thank you. Fine. Actually, this topic has been already taught to you. Granulomas conditions of the nose and PNS. I just thought to revise it. Okay, before going to the class, roll number. Roll number 36. Roll number 36. Can you unmute yourself and roll number 36? Now he's offline. Wow. Roll number 113. Roll number 113. 113. Roll number 56. Roll number 110. 110. I'm audible, right? Roll number 110. No one is responding, okay? You don't want to respond, or you are not there in the class? I would like to know why no one is talking. Actually, there's no point in teaching like this, but you guys could respond and hello. Someone has unmuted their hello. Who is the one who has unmuted them? Everyone is muted. From where did the sound come? You guys need to respond, okay? If you're not responding, if you're not able to understand, you have to let us know so that we can tell you again. These classes are for you, okay? So you fine. I'll do my work. You also, it's better once you go through. I'm also sending my PPTs so that if you don't want to study the textbooks at all, at least you read out the PPTs in your phone. I think no, take it seriously because you just have only 3 months now. You won't be called here. Definitely, your exams will be conducted, and you have to write your theory. So don't think that the university will give you a chance, so that if you, however you write, you will get passed. The examination will happen as it is. If you don't read and come, and practicals will also be conducted, but most likely the patients won't be there. You are directly, the viva questions will be asked on your theory, so you have to be prepared for that. Okay, so so don't take it easily. It's better you just start your preparation. You have three subjects, right? You have to cover three subjects, so start preparing from now on. So I'll just revise today's class, that is granulomas of the nose and PNS. So I just wanted to ask what do you mean by granuloma and what are different types of granulomas, but no one responded. Fine. So coming to the definition, granulomas, it is a distinctive pattern of chronic inflammation which is characterized by aggregates of activated macrophages that assume a squamous cell-like appearance. When the patient comes to you, you feel that okay, this might be a carcinoma, but yeah, they look like a carcinoma. But when you do a biopsy or you do some examinations, you get under the microscope, you get a histological picture like it's a chronic inflammation where you can see activated macrophages are aggregated. So these conditions are known as granulomas of the nose and PNS, paranasal sinus. But it still gives rise to greatest confusion and diagnostic difficulties. It is not that easy to differentiate between various granulomatous conditions. So it's still a test for the pathologist as well as the clinician. So what are the principal components you find when you do a histological examination? You will see a lot of macrophages, epithelioid cells, and multinucleated giant cells. Okay. And generally, the other features which you see in the picture are necrosis and the vasculitis. You see, there's a lot of the inflammation of the blood vessels is there, and also the necrosis of the tissue. So when these features are seen, you can come to a diagnosis of granulomas. Whereas in cancers, you won't see much of vasculitis. You will be mostly seeing angiogenesis and all, but not of vasculitis. So, and previous therapies may have altered the clinical condition of and a conclusive diagnostic biopsy is not obtained by the clinician. So coming to the classification, they can be divided into two, that is specific and non-specific. Specific types are tuberculosis, leprosy, syphilis, scleroma, that is rhinoscleroma, actinomycosis, some fungal infections, aspergillosis, mucormycosis, rhinosporidiosis, leishmaniasis, acquired immunodeficiency syndromes. All these are some of the specific types of granulomatous conditions of the nose and paranasal sinuses. Whereas the non-specific type are sarcoidosis, which are the systemic conditions, vaginous granulomatosis, and sinonasal lymphoma. So we will discuss some of these detailedly. Coming to the one which is the most common type of granulomatous condition, that is tuberculosis. But actually, the tuberculosis is the most common condition where you can get a granulomatous disease, but that is very rare. And it is almost always associated with primary pulmonary tuberculosis. So when the patient has already primary pulmonary tuberculosis, so that patient can have a chance of getting a granulomatous conditions of the nose and PNS. The types of the conditions are the TB ulcerative type, or it can be a nodular type or a polypoidal type. And the most common part that is involved in the TB are anterior part of the septum, inferior turbinate, and anterior choana. So this condition is most likely situated in the anterior half. Means you will see in the anterior part of the septum, that is in the cartilaginous part of the septum, or inferior turbinate, and the anterior choana. So what is anterior choana and the posterior choana? Means choana is the part which is the connection between the nasal cavity and the nasopharynx, right? So that's the opening at the posterior end of the nasal cavity. So something anterior to that choana is generally tuberculosis. That means nasopharynx is not that much involved in TB. So what do you see on clinical examination? You see a bright red nodular thickening of the septum. So as the cartilaginous part of the septum is involved, you see that the septum has turned into bright red nodular thickening. Sometimes due to this thickening, then fibrosis, then ulceration, necrosis can happen, and finally septal ulcerations or perforations are seen. And nasal block is due to fibrosis or the stenosis. So the tissue, the mucosa over that nasal wall can get fibrosed or can get stenosed. So the patient will have nasal block. So microscopically, what will you see? You will see some thyroid granulomas, Langerhans giant cell, and extensive caseation. So these are the histological picture things which you need to tell when you say that it's a tuberculosis. You need to find this Langerhans giant cells and extensive caseation. Then only you can say that this is a TB. Commonly, it's an acid-fast and the alcohol-fast bacilli. Their presence is confirmatory diagnosis. So when you go for a microbiological examination, when the bacilli is acid-fast and alcohol-fast, both are detected, then it's a confirmatory diagnosis for TB. Another condition known as lupus vulgaris, that is TB lesion of the skin of the nose. When only the skin of the nose is involved, then that condition is known as lupus vulgaris. It means the same bright red thickening of the skin will be seen. So if the septum is seen, then it is TB. But when only the skin is involved, then you can term the coin as condition as lupus vulgaris. It will simulate the squamous cell carcinoma. Okay. So what's the treatment? For any tuberculosis, the only treatment will be ATT, anti-tubercular therapy. Okay. So, but before starting ATT, you need to get a routine checkup like urea, you have to check it, creatinine, SGOT, SGPT, means you need to do the liver function test before starting ATT, because these drugs are sometimes they deteriorate the condition when the patient has already LFTs, derailed LFTs. So, and we have to give the treatment for 6 to 9 months. The drugs used are isoniazid, rifampicin, and pyrazinamide. Coming to the next condition known as leprosy. So leprosy frequently involves the nose. As TB was the rare condition, means the patient might have a primary TB, but that not indicates that he will definitely have a TB of the nose. But when the condition is of the leprosy, the nose is also definitely gets involved. That they want to. Now leprosy has been totally eradicated, but still there are some cases there. But total eradication has happened in India, so we don't see often leprosy cases. So the frequently involves nose, and it's often the first site of manifestation. Nose may be an important site of discharge of bacilli. It is actually less acid fast resistant and not alcohol fast. So when you do a microbiological examination and you get to know that it's not an alcohol fast and only less acid fast resistant, then you can come to a diagnosis of leprosy. And as you know, there are 5 types of leprosy, means lepromatous leprosy, indeterminate leprosy, borderline leprosy. Like so, there's a wide range of disease between lepromatous and tubercular type of leprosy. Nodular thickening of the mucous membrane and perforation of the cartilage septum will, as you see in the TB, most of the granulomatous conditions will cause the same. So there will be thickening of the mucous membrane and the perforation can happen at the cartilaginous septum. So how do you treat it? You give a dapsone or a sulfoxone sodium. So the as you treat the bacilli, leprosy bacilli, the tissue will heal, and if at all required, if it is already perforated, then you can go for a small graft. You can you put a small graft over there so that the perforation gets closed. Coming to the next condition known as syphilis. Incidence is reduced due to widespread use of antibiotics in the venereal disease. So nowadays, syphilis conditions are well treated. So we give some penicillins and all. So definitely there is less incidence now. So it is transmitted venerally or congenitally. Nose is always involved in the conditions of nose syphilis. We have congenital syphilis and we have other types of primary, tertiary, and secondary syphilis. So coming to congenital, the early symptoms are simple catarrhal rhinitis or excoriation of the nasal vestibule. So the patient can have early symptoms like simple catarrhal rhinitis. Means, the patient will have some only nasal discharge, and after the discharge, it gets dried up and it will form an excoriation. And what are the late manifestations of congenital syphilis? The patient will have gamma formation, A saddle nose deformity will form, perforation of the septum or the palate, or secondary atrophic rhinitis. So these are the manifestations of a late late manifestations of congenital syphilis. Then coming to the other types, that is primary, secondary, and tertiary. In the primary, the chancre is rare, but it affects the anterior part of septum and the skin of the vestibule. These are generally hard, painless, ulcerated papules. So when the patient has an hard, painless, ulcerated papules, then you can think in the line of syphilis, that is primary. The when you call it as a secondary, this is the most infectious stage, and it starts with a simple catarrhal rhinitis with white mucus patches, and there is some crusting or fissuring of the nasal vestibule. So when there are papules, it is called as primary. But when only simple catarrhal rhinitis is present with some white patches, then you can call, and crusting is there, then you can call it as a secondary, which is the most infectious stage. And the last stage is that is the tertiary stage, where the gamma formations take place, and the most common site is septum. Ulceration, perforation of the bony septum can occur. Offensive nasal discharge, bleeding, and crusting. And due to the loss of the cartilages and the bone, the saddle nose deformity will occur. That is involvement of the nasal bones, which have gradually collapsed due to extensive contraction of the scar tissue. And when you see in the microscope, you see areas of necrosis alternative with granulation tissue. How do you do? How do you investigate? We go for a culture. We do the staining with alkaline phosphatate, and we also do a para-aminosalicylic acid, Alcian blue staining, and we also do a soft tissue scan. Coming to the next condition, rhinoscleromas. So in syphilis, you just need to remember only the conditions, that is congenital syphilis, which has early and late manifestations, and the other primary, secondary, and tertiary, how they see. And how do you treat? You give it by giving antibiotics, that is penicillins. Penicillins are the drug of choice for syphilis. Then coming to the next condition is rhinoscleroma. Rhinoscleroma is also a bacterial infection, so it is a chronic granulomatous lesion occurring primarily in nose and nasopharynx, which can also affect other sites known as larynx and trachea. So this is a condition which involves nose, nasopharynx, like larynx and trachea. That is the respiratory tract. So this is the chronic granulomatous lesion infection, which can involve the upper respiratory tract. It affects it generally it affects any age, but most common in males. And the organism which is most commonly involved is Klebsiella rhinoscleromatosis, also known as fish bacilli. Klebsiella rhinoscleromatus. And when you see the histological picture under the microscope, you can see that there are granulations in the submucosa and the most characteristic cells, that is Miculic cells. You can see the Miculic cells and Russell bodies. So when you find Miculic cells and Russell bodies, then that condition is known as rhinoscleroma. So what are Miculic cells? They are the large cell with central nucleus and a vacuolated cytoplasm. And what are Russell bodies? These are the modified plasma cells, dark staining bodies with eccentric nucleus seen around the Miculic cells. So Russell bodies are seen around the Miculic cells. So when these two cells are seen, when the Miculics and the Russell bodies are seen, then you can come to a diagnosis of rhinoscleroma. It also has some stages. The first stage is that is catarrhal, which presents as foul-smelling purulent discharge similar to common cold. Then the granulomas occur, that is nodular granulomatous lesion within the nasal cavities, and the disease may extend into sinuses, nasopharynx, larynx, trachea, nasolacrimal system, and even intracranial. The nasal tip and the ala may be involved, then that condition known as hebranos. When the nasal tip and the ala are involved, then they are known as hebranos. And the last stage is known as cicatrizing stage. So it starts with catarrhal, continues as granuloma, and the last stage is cicatrization, that is characterized by the fibrosis and the cicatral scarring that with consequent distortion. It can also involve the when it involves the nasopharynx, the fibrosis of the eustachian tube opening can occur. That will lead to otitis media with effusion and also chronic separate otitis media. The most common site involved is the anterior part of septum, and the commonest presentation is nasal obstruction. So most of the granulomatous conditions, you'll have the same pathophysiology is the same. Means initially it will start with say a catral stage, that is mostly some rhinitis and all. Then it will start the formation of the granulomas, and at last the fibrosis will start to occur. So bacilli are better demonstrated by silver impigmentation stains such as Warthin-Sturm or James stain. So you need to remember this name, James stain. Okay, so Giemsa stain is one of the stain where you can diagnose bacilli. You can inoculate it, demonstrate, and immunohistochemistry detection of the capsular antigen 3 can also be done. How do you treat? Generally, this streptomycin is given to them, and sometimes a combination of radiotherapy, radiation and streptomycin are found to be the best method of treatment. And after doing a medical treatment, you can also go for a surgery to remove the granulations with cautery or laser. And ultimately, you have to do a plastic reconstruction. As most of the cartilage and the bone have been destroyed, necrosed. So once you remove the granulomas, then you can augment it with some doing some rhinoplasty and all. So what rhinosporidiosis? So this is another condition which is which is the which is by Rhinosporidium seaberry. So this is the organism which causes rhinosporidiosis and which predominantly affects the mucous membranes of nose and nasopharynx, characterized by the formation of friable, bleeding papillomatous or polypoid lesions. So when the patient comes to with nasal obstruction and bleeding per nose, and on examination you see some friable bleeding papillomatous or polypoid lesions, then you can go for a diagnosis of rhinosporidiosis. So it may also involve lips, palate, uvula, maxilla, conjunctiva, lacrimal sac, epiglottis, larynx, trachea, bronchus, ears, scalp, skin, and external genitalia. So see, you can see the spread. It can spread to any part, almost adjacent to nose and esophagus. Any part can be involved. It cannot be cultured. See, rhinosporidiosis, seaberry cannot be cultured. It cannot be transferred from human to animal host. Generally, most commonly seen in the males and seen in the age group of 20 to 40 years, and 88% cases from India and Sri Lanka. So these are the most generally in the tropical climate. Rhinosporidium seaberry grows more in the tropical climate. So our southern India and the Sri Lanka, you see a lot of cases. How are these transmitted? Bathing in infected waters, droplet infection by cattle dung or dust, contact transmission by contaminated fingernails or cutaneous lesions. So what are the symptoms? Epistaxis, nasal block and discharge. What are the signs? You see a pedunculated friable mass with granular surface resembling strawberry studded with sporangia showing as white dots. So that will be like a pedunculated friable mass which will be seen like a strawberry. And it involves septum and turbinates. The terminates involved are inferior and middle. The nasal mucosa, it will be hyperemic, edematous, and covered with copious secretions. And it bleeds on touch. So when a mass is bleeding on touch, and then the differential diagnosis for you will be rhinosporidiosis or a JNA, depending on the age. If it's in the adolescent age, then it can be JNA. But generally, in the 20 to 40 years of age, if you are seeing it, and more the person's profession also is important. Means if they are working in waters more, then and they live in the tropical climate, then you can have rhinosporidiosis as one of your differential diagnosis. So when you do a microscopic examination, biopsy, histopathology, then you can confirm your diagnosis. Romanowski. So this one, this is the name, stains. Giemsa stain was for rhinoscleroma, and for rhinosporidiosis, Romanowski stain is used. So how do you treat it? Wide excision with a cutting diathermy and a cautery to the base of the lesion. If you don't cauterize the base of the lesion, then the recurrence chances are more. So you have to totally cauterize it. And sometimes if it's a systemic rhinosporidiosis, then you have to go for a dapsone and amphotericin B. As this is a fungal infection, so you have to go for a dapsone, amphotericin B. Coming to another common fungal infections, aspergillosis. So it is the commonest fungal infection of the nose and paranasal sinuses, and we have three species causing them. The most commonly is Aspergillus fumigatus. That is 90% of the cases will have Aspergillus fumigatus, whereas the Aspergillus niger and Aspergillus flavus are some other species that can also cause aspergillosis. They are identified by the septate hyphae and dichotomous branching at an angle of 45 degrees. So there are some other fungal organisms also, but how do you diagnose that these are Aspergillus only? So you have so these are the findings identified by septate hyphae and dichotomous branching at an angle of 45 degrees. These are generally filamentous fungus, saprophytes in soil and decaying matter. The spread is through airborne, and there are four types actually: non-invasive, that is Aspergilloma, allergic, invasive, and fulminant. Both non-invasive and allergic, they are extra mucosal diseases and benign. So these are the benign conditions. So coming to the non-invasive type of aspergillosis, also known as aspergilloma or a fungal ball, it behaves as chronic sinusitis and should be suspected in any refractory case. When you are treating the sinusitis again and again, the patient is coming to you back again and again, then you need to once think about this aspergillus or gilloma or the fungal ball. So what is the characteristic finding? You see a green brown sludge filling the sinus cavity, that is the antrum. And when you do a X-ray or a CT scan, you will see some calcium deposits. So that will it involves only one of the maxillary sinus, and when on doing repeated exams, treatment, if they're recurring, then aspergillosis can be say, one of the finding. You have to do an X-ray and you will see that the calcium deposits are seen. So that is non-invasive type of aspergillosis. What is allergic? It is combination of type 1 and type 3 immune responses to aspergillus antigen. Generally, young adults with history of asthma or polyps, they have this allergic aspergillosis. They have thick inspissated mucus, and that mucus will contain eosinophils and charcoal laden crystals. The fungal hyphae are very scanty but can be identified by special stains, that is silver methamine stain is you can, when you do a silver methamine stain, you can diagnose as aspergillosis allergic. Then coming to the invasive type, it is not that common. It behaves like malignant neoplasm and spread to adjacent structures, that is soft tissue of the cheek in orbit. Proptosis may be the prominent feature, and it is slowly progressive but locally destructive. The bone gets eroded. Progressive fibrotic or sclerosing form can also occur. So invasive type is very rare, but when it happens, it involves the cheek in orbit. So proptosis can be a presenting feature. Another term known as fulminant. It is a rapid progressive. Slowly progressive is invasive. When it is a rapid progressive angio-invasive destruction which carries high mortality and usually affects immunocompromised patients, then it is a fulminant type of aspergillosis. Intracranial extension is seen generally in 1/5 of the cases, even with treatment. And after when you do a histopathological examination, you see in a you see fibrosis, and also you see granulomatous response, okay, when you do a histopathology. So how do you investigate? We do a serology test and a skin test for antigen, the aspergillosis, fresh nasal scrapings, mucosa and biopsy. So you investigate by doing biopsy, you do a scraping, you do serology, skin test. Then treatment is not for non-invasive, you can do only surgical debridement and sinus ventilation. For allergic, you have to do debridement along with corticosteroids. And for the invasive and the fulminant, more radical surgery in the form of excentration of the affected area and combined with IV amphotericin. So you have to give some antivirals, amphotericin B. Coming to one of the highest mortality seen in the granulomatous meningitis, that is mucormycosis. It's very aggressive and opportunistic infection due to fungi of the order mucorales, and most commonly associated with diabetic ketosis, uremic acidosis, leukemia, malnutrition, steroids, anti-metabolites. Means when the patient is highly immunocompromised, chance of getting mucormycosis is very high. It has remarkable affinity for arteries, and by dissecting the internal elastic lamina from the media, leads to extensive endothelial damage and thrombosis. So the patient, why the mortality is very high when the patient is having mucormycosis, because they have very much affinity for the arteries. They dissect the layer or internal elastic lamina of the media, and they will lead to thrombosis. So first the arteries are involved, then the veins, and at last the lymphatics are also involved. Pathologically, there is a mixed picture of inflammatory and necrotic changes. So what are the forms of mucormycosis? It can be a rhinocerebral, that is the most common, means the nose will be involved, and the brain, that is the cranium, will also be involved. So the rhinocerebral is the one of the most common type of mucormycosis. The other forms are pulmonary, ocular, superficial, and disseminated. So what is rhinocerebral? So it can also be rhinomaxillary and rhino-orbitocerebral forms. So rhino-orbitocerebral forms is the highest, having the highest mortality. Usually commences in nose, extend either by direct extension of or intravascularity to invade the PNS, orbit, cribriform plate, meninges, and brain. Proptosis will be seen ophthalmoplegia and blindness involves of and after the involvement of the CNS. Initially, there will be pain in the face and orbit is out of proportion to the physical signs, but later a characteristic rhinological finding of a black necrotic turbinates resembling a mass of dried clotted blood is seen. So initially the pain, and there will be pain, but later you can see a black necrotic turbinates resembling a mass of dried clotted blood is seen. So generally it starts as a unilateral condition, a gangrene and perforation of the hard and soft pellets is seen, palatine arteries are involved. When you do a sinus radiograph, thickening of the lining of the sinuses, spotty destruction of the bony walls, and no fluid levels are seen. When you do an MRI, vascular and intracranial involvement is identified, and they are confirmed by biopsy. So how do you treat it? Um, by control of original respiratory condition, heparinization, as the lot of thrombosis is there, then you have to give some heparin. Then systemic amphotericin and local drainage and debridement has to be done. Orbital excentration mandatory for ophthalmoplegia and loss of vision is anticipated. So these were the conditions, the specific type. Now coming to the non-specific type. So sarcoidosis is a systemic disease. So this is one of the specific type of granulomatous conditions of the nose. By definition, it is a chronic systemic disease of unknown etiology, which is clinically characterized by involvement of the virtually every organ in the body with a non-caseating granulomas. So when we had caseating granulomas, that we considered them as TB. But when you see a non-caseating granulomatous inflammation and it's a systemic disease, then you can come to a diagnosis of sarcoidosis. Most common involved organs are lymph nodes, skin, lungs, liver, spleen, and small bones of hand and feet. Sarcoid lesions may affect the nose in three ways. When only the skin is involved, the deep granulomatous plaques may occupy the full thickness of the dermis to produce bulbous red or violet skin lesions. Nasal bones can also be involved. With the nasal bridge becomes swollen and X-rays may show translucent deposits. And then the nasal mucosa. So only skin can be involved, or the nasal bone can be involved, and or the nasal mucosa. So usually over nasal septum or inferior turbinate, comprising of yellow or grayish, slightly raised nodules. When you see on the septum, nasal block will be present, mucopurulent or sometimes blood-stained discharge and crusting are seen. Saddling of the nose is seen. Synechian stenosis may occur. Histopathology, epithelioid cell tubercles without caseation convert into hyaline fibrous tissue. So how do you manage? The patient, we do an ESR examination, serum calcium, serum ACE. So after doing all this, then chest X-ray is done. TWIMS test is also done, but so it's actually not such specific. Skin biopsy positive 90%. And how do you treat it? We give nasal alkaline nasal douching or topical steroids and systemic steroids. Coming to one more condition known as vaginous granulomatosis. So it's the chronic granulomatous condition of unknown origin, probably autoimmune, which occurs in multiple organs characterized by necrotizing granulomas within the nasal cavity and the respiratory tract, a generalized vasculitis and a focal form of glomerulonephritis. So when there is involvement of the kidney, lungs, and the nose, so when these three are involved, you can suspect when you see a chronic granulomatous condition involving these three, then you can think of vaginous granulomatosis. So etiology is unknown. Current evidence: the vaginous represents a hypersensitivity reaction, perhaps to an antigen that gains access to the host via respiratory tract. So there will be vasculitis, will be seen, hypersensitivity. For generally seen in fourth and fifth decade, slight male predominance, and the sites involved are nose, sinuses, subglottis, trachea, bronchus, lungs, kidneys, skin, sclera, and joints. So coming to the nose, persistent rhinorrhea will be seen, epistaxis, nasal deformity, nasal obstruction, headache, and facial pain. So these are the manifestations at the nose. Mucosal edema will be seen nodular. So on clinical examination, you will see that the patient will have mucosal edema, nodular lesions, crust formations, ulcerations, loss of septal cartilage, and septal perforations. What are the pulmonary manifestations? The patient will come to you with cough, hemoptysis, and pleuritic pain. Lung cavities and lung abscess can also be seen on doing examinations. Renal, the patient will come to you with hematuria and decreased urine output. So on diagnosis, the segmental or focal glomerulonephritis with red cell cast and RBCs in urine can be found. So vaginous will involve generally the nose, lungs, and the kidney. They can also involve ocular. So when the ocular manifestations are corneal ulcerations, conjunctivitis, scleritis, retinal artery thrombosis, and proptosis. Whereas oral, it is diffuse hyperplastic granular lesions of the gingiva, extensive ulcerative stomatitis. Larynx and trachea. So pharyngitis and laryngitis due to the extension of infection from the nasopharynx, and subglottic inflammation and stenosis can occur due to granulomatous stricture. Otological. The patient, due to the scarring or the stenosis of the eustachian tube opening, so the patient can have OME, otitis media effusion, and also CSOM. When there is a problem with when the otitis media effusion is there, the patient definitely will have conductive hearing loss. Sometimes facial paralysis can also happen. So when you do a histology, the vasculitis is generally seen, so it is mandatory for diagnosing. Granulomas of epithelial cells may be seen with fibrinoid necrosis, and multinucleated giant cells and eosinophils are seen. So investigation. So you do an ASR, you do urine examination, you do ANCA, anti-nucleocytophilic antibodies, chest X-ray, nasal biopsy, and renal function test. So these are the tests we do. And how do you treat it? We do it by chemotherapy and steroids. Azathioprine is given, cyclophosphamide, methotrexate, and prednisolone. So these are the drugs to be given. And the last topic, that is sinonasal lymphoma. This is also one of the non-specific type of granulomatous conditions. It is a malignancy lymphoma of the sinonasal origin, generalized lymphoma involving nasal tract. So nose and sinus is rarely involved. Walde's ring often involved, and biopsy from Walde's ring is taken. Malignant lymphoma of the Walde's ring, so large cell histiocytic type, 85% is the most common type, which is very diffuse. And the nose will have epistaxis, nose block, swelling of the maxillary area. Peripheral sinonasal T cell lymphoma is also one of the type, where the nose there will be destruction and of the midfacial region, diagnosed by biopsy and immunohistochemistry, cytochemistry, and the treatment is radiotherapy and chemotherapy. Eosinophilic granuloma. This is another type of the sinonasal lymphomas, which is cause is unknown. Hyperplasia of the Langerhans cell type histiocytes. Skull is the most common site. Microscopic, soft and yellow or brown, red brown color. Biopsy is obtained. On microscopy, you can see histiocytic cells with eosinophils. Treatment is by curettage, excision, or radiotherapy and chemotherapy. Giant cell reparative granuloma. most commonly seen in children and young adults. It's a benign bony condition. It's a benign osseous lesion. The giant cells contain nuclei and surrounded by spindle-celled nuclei. Cholesterol granuloma, most commonly seen in the mastoid hair cells and paranasal sinus, that is frontal. It's a granulomatous condition for foreign body giant cells. Sorry, FP giant cells surrounding clefts. Cholesteatoma may coexist with cholesterol granuloma, and treatment is surgical removal. So these are some of the conditions, granulomatous conditions of the nose. Okay, so I'll share this PPT with you. Just once go through this, and you can expect some short answers or very short answers from these. So, but just once go through these. Okay. Okay. So if everyone has marked their attendance, then I'm closing this class. Thank you.